It's now a pleasure to show you a recorded case, which we recorded actually these days, so quite live. So I given this presentation quite live. So young patient, post-IV drug with an occlusion of his right common femoral vein. We are fully aware of all these patients with having severe post-thrombotic syndrome after long period of IV drug abuse. And here's a typical case I would like to show you, and also to share with you a new stent which came to the European market recently, the Beyond stent from Bentley. So how we proceed in this patient with an ulceration on the right side. So you could see the femoral vein itself is open. So we stick into the femoral vein using a 10 French sheath. This is the diagnostic phlebography. As you could see, this is the outflow, maybe some little post-thrombotic changes. The issue with all these post-IV drug abuse patients is a totally destroyed common femoral groin, which looks very ugly. There's just scar tissue. There's really nothing. There's just scar tissue. So it's always difficult to penetrate to this non-existing vessel region. What we are usually doing is to bring the sheath as possible as we could, then support a guide wire, usually a stiff Terumo angle guide wire, supported here by the Navicross in this case. Then we try to make our way through this scar tissue here, as you could see here. This is something which really takes time. You need to find 1,000 ways actually to come up with the wire here. So we tried a couple of times here to really bring that wire up, and you could see we always went into collaterals, ascending collaterals, collars to the contralateral side. So it's important to perform a lot of angulations here to really penetrate this, not very long occlusion. And then we finally make it up. But in this case, you could see we failed. We were somewhere outside the external iliac vein, not finding the true lumen here from distal. But this side, by this time, it's usually time to discuss if an up and over or transjugular approach might be an option, and then work from both sides through this occlusion. This is what we also did here. Even that it looked nice from distal, we were outside of the original vessel, and this happens unfortunately quite often. So then we prepared everything for an up and over maneuver in this case. Of course, you could also do a transjugular access as mentioned. My preferred choice is in most of the cases to use an up and over maneuver. Then you also have the chance really to perform balloon angioplasty or even standing from the contralateral side. So for that purpose, we usually use an Oscos durable sheath. This is a 10 French Oscos durable sheath, as you could see here, which we brought up from the left groin. And with the nice behavior of this Oscos sheet, it's very easy to bring this sheet very stable into the common iliac vein on the right side. As you could see here, you can curve the tip and really push the catheter into that common iliac vein. And you could see that is anchored very well here in this proximal part. There's the internal vein, and then we did the same maneuver here. We supported a stiff Terumo wire from the contralateral side, and then try to do a meet maneuver from distal and proximal. And here we finally made it from contralateral into the original external vein here. And this is always the moment where you say, okay, this could be a successful case, even with this totally destroyed common femoral, as you now have access from both sides to that, to this area, and can definitely bring a wire either ipsilateral or contralateral through that occlusion. So that's what we did here, and that's always helpful to do this with 4 hands. So it's like a piano. It's always good to have an experienced assistant beside of you, so you can penetrate from both sides. And here we made it with the contralateral penetration, brought the wire through, started with small ballooning. A large balloon was even not able to bring in, but with this ballooning, we had the chance really also to advance the Oscos sheet very deeply into the diseased area and push the balloon very, very heavily forward, which is always very difficult through this tissue, this scar tissue. and you need a lot of power to really penetrate. And so then we ballooned here from up and over the camphor vein with an, I think it was an 8 millimeter balloon. And after a deflation of the balloon, I then tried to bring the wire from ipsilateral up. And as you could see here, then suddenly you have the chance, as you created a channel from up and over, that the ipsilateral wire then has the chance to come up, and then you have that working wire from ipsilateral suddenly in, and then you can exchange this ipsilateral wire to an amplatz superstiff wire. Yeah, and then we did this after exchanging to an amplatz superstiff wire here, ballooning with large balloons, dedicated Atlas gold balloon here. And now you see the issue here, this tightening of the balloon here even needs 12, 14 atmosphere to really crack this scar tissue. Then you have a channel at least with what you can use to work further on. And by this time, it's usually time to perform an IVUS to really learn about correct sizing, about correct landing zone. Do we are dealing even with more and complex PTS, even proximal? And here in the IVUS analysis, you could see that also the proximal external iliac vein and partially also with the com iliac vein on the right side was diseased. So therefore, we then, based on this angio analysis, decided to stent the whole track of the iliac system. This is the advancement of the 9 French Pippin PV catheter from Philips, the Vision PV, I'm sorry. And the good thing is you have also markers on this catheter. This is the new stent here, which we use now. It's a pin and pull technique, 10 French system, a laser cut dedicated venous stent from Bentley, as mentioned, called the Beyond stent. This is a 14120 stent here. The pin and pull maneuver is shown here. The stent nicely opens, no foreshortening, no jumping, very precise implantation. Of course, like with all these pin and pull systems, very slowly deployment of the stent is always recommended. Yeah, this is the first stent implantation. Then, of course, we also needed to put a second stent in here, and we decided to implant here a 12 millimeter stent here, which is now brought forward. Also, a Beyond stent overlap, as with all stenting in the iliac system, 2 centimeters, which we tried also here. And of course, we tried to let this stent land just at the level of the profunda, or slightly above the profunda inflow, so not harvesting the profunda with stent struts. And I think that is important, and the way always these stents should be implanted. Yeah, and after that, of course, intensive balloon angioplasty, as you could see here, with a 14 millimeter Atlas gold balloon, proximal 12 millimeter balloon distal. And with that, you can really nicely open the stent, which I personally believe is very important to do this post-dilatation. Otherwise, you create an artificial outflow obstruction. Yeah, and here also, then you could see that there was a very good inflow after 2-3 heart cycles, and outflow, no persisting of the contrast, going up directly with the injection. Yeah, so this was the new stent. Thank you very much for the opportunity to show the stent.